All right, thank you very much. So, hi, I'm David Crane. I'm the CEO of Door-to-Door Health. We spend 80% of our country's $3.5 trillion annual healthcare cost on people with chronic conditions, in large part because of two factors. Primary medical care isn't working like it used to, and more costs are shifting to the consumer, driving delays in people getting medical care until it becomes a trip to the emergency room. This has created an $800 billion total addressable market and a $69 billion serviceable market for our services. So here's what we're doing. We're reinventing the delivery of primary medical care. We're a primary medical care practice. And we're launching a new kind of unlimited, home-based, tech-enabled primary care service for $49 per month that makes medical care convenient and affordable for lower-income households, saving our clients money and saving hundreds of billions in healthcare costs. Our services integrate an in-person visit at the patient's home with things like telehealth for follow-up and medication management, remote patient monitoring tools to ensure care plan adherence, and connections to community service organizations to assist with things that are under the umbrella of social determinants of health, like food security, transportation, and access to affordable prescriptions. Doing all of this while reducing our operating costs compared to a traditional primary care practice by 30% and approaching 60% gross margins previously unheard of in primary care. So investors in this space see huge potential returns, and there's a lot of activity in the space right now. In the last 8 months alone, only $1.5 billion has been invested in just 5 primary care companies. And this is just the beginning to serve over 300 million Americans. Our leadership team has launched 4 healthcare companies with 2 exits, including one of the largest primary care practices in the state of Nevada, serving over 40,000 patients and handling over 140,000 patient encounters per year. Door-to-Door Health has a revenue-generating pilot running in the Las Vegas market and patient referral and marketing partnerships in place today, like the Southern Nevada Regional Housing Authority, PAM Rehabilitation Hospitals, and University Medical Center. These represent over 70,000 prospective patients for us in the Las Vegas market alone, and we anticipate about $20,000 in monthly revenue once we hit general launch. And just those partners alone will generate about $600,000 in revenue over 12 months from the date of launch. We expect to break even in third quarter of 2021 and reach 91 million in revenue by 2024. So our revenue model is really interesting. We accept insurance reimbursement for people who have it, things like Medicare and Medicaid and TRICARE for veterans, United Healthcare, Blue Cross Blue Shield, and many others. And we're already credentialed to accept reimbursements from those organizations. But most important, we created a first of its kind concierge for everyone membership program for people and employers who pay costs out of pocket, so everyone can get the care they need before it becomes an ambulance ride to the ER. The Concierge for Everyone program has 2 components. The membership plan I mentioned, starting as low as $49 a month for unlimited primary care services, and a pay-as-you-go plan that guarantees a low rate of $99 per visit for episodic primary care visits. Our patient acquisition plan is reflective of the relationships we have in place today and is centered on creating partnerships in each community with organizations that treat, support, or employ the populations we serve, like affordable housing developers. In parallel, we'll be testing direct-to-consumer campaigns targeted at people with high-deductible health plans using both digital and traditional marketing channels. So, competitively, there are 3 kinds of medical care providers. There's bricks and mortar primary care practices like One Medical and Iora Health. I call these consumer experience practices because they offer things like yoga studios and after-hours access memberships, but really they're still reliant on patients coming to them. They have buildings and they practice pretty much traditional primary care. Then there's mobile urgent care companies like Dispatch Health, Heal, and Pager. I call these hit and run providers because they see patients for episodic sick visits with no ongoing relationship, no care plan development or follow-up. And finally, there are pure remote telehealth providers that perform limited medical services with no ability to deliver the hands-on, comprehensive primary medical care people need to manage their health and in particular chronic conditions. So Door-to-Door Health delivers the convenience of at-home visits and the comprehensive primary care services of bricks and mortar practices, all while reducing operating costs and charging a more affordable price than any of our competitors. We're seeking a seed investment of $1 million with 262,500 committed at this point at a $3 million pre-money value.
So that's it for your presentation, David. It seemed like you were near the end too. I'm gonna ask you to unmute one more time so we can get into the question part.
Oh, I was under 5 minutes all day until just now.
That's how it goes sometimes.
Yeah,
Jeff,
actually, this was the end of it. So that was the last slide. Sorry about that.
That's excellent. Okay. Jeff, did you have a comment?
I have a question. Your CAC to LTV, you've got a 5-year LTV and like an $88 CAC. Take me through what's in the $88 and why 5 years? That seems like a long time for an LTV.
Well, actually, people who have doctors tend to stay with them a really long time. So if they're happy with your service, it's really, honestly, it's longer than 5 years. I've had my doctor for 22 years. So, 5 years, I think, is very realistic. The $88 comes from the fact that the way we sell is in blocks. So for example, this partnership we have with the Southern Nevada Regional Housing Authority, they've agreed to market our services. We're going to supply them with the tools to do it, but it's on their nickel. They're going to put flyers out and door hangers out and educate their property managers on our system and our services on their nickel. And so our cost of customer acquisition is extremely low. And we'll get probably 2,000 to 3,000 people out of that relationship alone at minimum, probably over the first 12 months. And if we bring on an employer with, X number of employees, a block at a time. So the cost of customer acquisition really is very low in the way we sell. The only thing that would change that is if we find traction in the direct-to-consumer space, that might cause it to go up a bit, but only if we get the ROI that we need off of the platforms that we use.
Okay. Is there anybody else that's doing this sort of subscription model outside of, the care that people subscribe to with their personal doctors, the concierge stuff?
Yeah, there's a few kind of one-off providers. There's a group in Detroit called Plum Medical that's doing this very successfully. They've now attracted over 5,000 patients in the Detroit market just to their specific practice, and it's membership only. The whole, direct provider care movement is kind of around this space, and these are individual practices that do this. So it's not just concierge anymore. It's actually these membership programs. But our focus is on a specific market for these things. And that's that kind of lower income market that has these high deductible plans. So there's actually quite a bit of proof of concept of this in the market already for these membership programs. And it's probably one of the fastest growing areas within primary care right now.
Do you see any political risk if the government starts to become more involved in our care?
Well, actually, that's a really good question, because if we're doing, this membership thing, that would obviously pretty much go away in a Medicare for all or universal healthcare environment. And so we built our model using a Medicare pricing. And so that's why we take Medicare today. And that's why we charge a Medicare rate for people who pay episodically. So we can be completely successful providing that same level of service, which is really the important part. It's the delivery, the care model that we deliver, not so much the revenue model. I'd be happy taking Medicare reimbursement all day long and not have to worry about billing anybody.
Okay, all right, I've dominated. I'll shut up now.
Okay, Maddie, go ahead, please.
Can you clarify that $49 membership? Is that for uninsured? Can you talk a little more about those financials and what that covers and what data you have to support?
Sure. So the $49, first of all, it is a spread. It starts at $49, it goes up to $69 depending upon age. So and for kids, it's $29 a month. So I just use the $49 for ease of discussion. But the, again, I just totally lost my train of thought. I apologize. Can you repeat the question?
Yes, who, is that for uninsured?
Oh, thank you. So it's for uninsured and underinsured. So I mentioned this high deductible health plan market. That's our primary focus, is these folks that have insurance, but because they have high deductible plans, and these are people who on average make less than $80,000 a year, they tend to be working. in many cases, they're working poor, but they make just enough not to qualify for Medicaid. And there's about 30% of the entire US population that falls into that bucket. And these folks are one of the primary reasons that we're driving costs so high, because they just either delay care because of cost, or they delay care because they can't take off work to go get medical care. And so they use the ER as primary care. And that's, because we're shifting so much cost to the consumer, we're actually creating our own problem. So that's our market. And the financial model behind it is, on average, a person sees a doctor about 3 times a year. A person with a chronic condition sees a doctor about 3 times a year. And in a regular insurance environment, the average reimbursement is about $125. So if you look at it from that standpoint, those folks have to be, profitable enough, making, $375. In our model, we'll be making $600, which is why we're able to drive the gross margins approaching, it's about 57% at scale.
Okay, Maddie, does that?
Yeah,
Whoops.
there's other companies or some reason to believe that people won't, if it's unlimited, take advantage of that and therefore affect your.
Well, when they sign up for unlimited, they do sign a little agreement. And one of the pieces of that agreement, says that if they start abusing the service, like some people are just lonely, and we know this. I mean, there's a lot of mental health issues out there. And so we do reserve the right to kind of limit, our interaction. However, we also use the tech to reduce the costs of those interactions. And we use these interactions smartly. So we don't always send someone out to their house. Depending upon what happens, if we see a result come back from a glucose meter that's connected to the internet, so they take their glucose, that data comes right back to us. And if it's an outlier result, we're not going to just send someone out there. The first thing we're going to do is, maybe secure message them, or maybe, call them, or maybe initiate a telehealth interaction. One of our nurse practitioners from their car can do it. And find out what's going on and whether they need to have any kind of additional intervention. So one of the reasons that we can deliver this so efficiently is because, unlike traditional practices, we've got a lot of options for how we can efficiently communicate and interact with our patients.
Okay, David, Stephen has a question.
Yep.
I definitely do. Tell me about the provider side of the equation. Without the providers, you're going to have the patients. In your model and what you've looked at, what's your patients per provider ratio, and
Sure.
how do you attract your providers to be available for the service?
So the first thing that's important to mention is about 95% of our care is delivered by nurse practitioners. So we will only be operating in states that allow nurse practitioners to practice at the top of their license. And today there's about 32 states that allow that. That's one of the reasons we're able to deliver a very cost-effective service. They make about half what a doctor makes, number one. The way we attract nurse practitioners is using kind of a gig economy model, because most nurse practitioners actually have full-time jobs, and they supplement those jobs with after hours and weekends and on their days off and so on. And so we can attract, and we've been successful at filling that nurse practitioner pipeline in Las Vegas, and we have a couple of them ready to jump on once we close funding. And it's exactly that. Now, once we get to scale, we're going to end up with a mix of FTE and and kind of gig economy, part-time independent contractors. So actually, the market that we have today, this kind of gig economy market, plays right into our staffing model for nurse practitioners. And then the ratio of patients to nurse practitioners, which is really interesting. A regular primary care practice will have about a 2,300 person patient panel per doctor. In our environment, we make actually a little bit more money with a 1,750 patient panel, person panel. So we can see fewer patients, make more money, which allows us to spend more time.
Okay, Steve, we're actually out of time. Did that answer your question? Do you have one more comment?
No, it's fine. I can do the math. I wanted to get to the revenue per provider number, but I can do math. So thank you.
Okay, so there were 2 questions. Somebody commented that this pitch was much better than the one you did a quarter ago. And
thank you.
Bill asks, how many patients do you expect at the end of year 2? What are you going to do in the other 18 states? And how does your average 335 compare to other large primary care practices? So be succinct.
Yeah, I can actually show you. So here's the number of patients in the thousands that will have year 1, 2, 3, 4, 5, or 4. And what was the rest of it? I'm sorry, you asked a bunch of them.
Okay, that was the number of patients. He asked, what are you going to do in the other 18 states that don't allow the nurse practitioners to practice at the top of their license?
Well, this is a assumption on my part, but what's been happening across the country is these laws are changing pretty rapidly. In fact, California has had this up like 3 times now, and it's going to pass one of these times, probably in the next year or two. So by the time we're in 32 states, my guess is we'll be able to go into 40 or 45, maybe even all 50.
Okay.
And there's plenty of business in the 32, even if that didn't happen. I'm not worried about it.
Okay, Bill, your question about the 335, is that dollars per? Why don't you just
Yeah,
ask the question, Bill?
I'll clarify it. Yes, it shows here a average rev per patient of 335. I was wondering how that compared to other large primary care practices.
So this is a blended model. That 335 is, I think that's what you're talking about on this slide. This is blended between the membership and the insurance model. So as the numbers I gave you a few minutes ago with the person seeing a doctor on average, 3 times, plus our membership model, because we're going to have a mix of memberships and insurance. So it'll actually bring down from the $600 a year down to this number. If we're successful in attracting and building that membership up as big as we hope, this number will go up.
Okay,
Okay.
but how does it, what do other primary care practices out there, big ones, whatever they are, how does it compare? Or do you have that number?
Yeah, well, it's going to be around $375 because if they're accepting insurance and the average number of times a patient sees a doctor is 3 times, the average reimbursement's $125. It's $375 from a Medicare reimbursement.
Great, thanks.
Yep.